Good afternoon, folks. Now, this discussion C deals with sedatives and antipsychotic medication drugs that carry a FDA warning, a mandated FDA warning about increased mortality in older adults with dementia are being prescribed more often to seniors. So that is today's discussion C. So let's dig into the presentation I made for you. Please sit back and enjoy. The article lays out a troubling but increasingly well-documented trend. Sedative antipsychotic medication drugs that carry a known FDA mandated warning about increased mortality in older adults with dementia are being prescribed more often to seniors. Drawing on a large national prescription claims database, the piece shows that use has risen sharply over the past decade, even though these medications offer limited benefit for dementia-related aggression and come with substantial risks. The article frames this as both a clinical and a systematic failure. Caregivers are desperate. Clinicians are pressured, and the care environment often leaves few alternatives. Why prescriptions are rising. The page makes clear that the increase is not driven by favorless prescribing, but by real high stakes crisis in dementia care. Acute behavioral emergencies. When a person with dementia is shouting through the night, wandering into unsafe areas, or becoming physically aggressive, caregivers face immediate danger and exhaustion. Antipsychotic drugs or antipsychotics can quiet these behaviors quickly, which makes them tempting in moments of crisis. Understaffed and overstretched care settings. Nursing homes, hospitals, and home care environments often lack the staff, training, or non-drug behavioral strategies. In these settings, medication becomes the fastest available tool, even when someone knows it's not ideal. Prescribing culture and geography. The article notes that prescribing patterns vary widely across regions, and clinicians sometimes clinicians, some areas have entrenched habits of using sedatives for older adults, and some clinicians, especially those trained decades ago, may rely more heavily on medications than on newer behavioral approaches. Caregiver, care, Caregiver distress and pressure. Families who are frightened, exhausted, or overwhelmed often plead for something that will calm their loved one. Clinicians may feel pressured to provide immediate relief, even when the long-term risks are significant. The clinical problem and evidence on harm. The article emphasizes a stark mismatch between how often these drugs are used and how little they help. Limited effectiveness. Antipsychotics do not treat dementia itself, and their ability to reduce aggression or psychosis is modest and inconsistent. Many patients do not improve meaningfully. Black box warning for mortality. These medications carry the FDA's strongest safety warning because they are associated with increased risk of death in older adults with dementia. Other serious harms. Beyond mortality, the drugs increase the risks of falls, fractures, sedation, cardiovascular events, and functional decline. Outcomes that can dramatically shorten independence and quality of life. The article's data underscores the scale of the issue. Any antipsychotic use among adults 65 plus rose nearly 52% from 2015 to 2024. Long-term use, 120 days a year, rose 65%. Rates were highest in adults 75 and older, combining from 3.42 to 5.12 per 100 people. Drivers beyond immediate clinical need. The page hints at deeper structural forces that shape prescribing, emotional burden on families and staff. When behaviors escalate, everyone involved feels desperate for relief. Medication becomes a symbol of taking action. Systematic gaps in dementia care. Many care settings lack access to geriatric psychiatry, dementia specialists, or behavioral consultants. Without these supports, non drug approaches can feel unrealistic. Institutional norms. In some facilities, sedatives sedative use becomes normalized over time, especially when staffing shortages make individualized care difficult. Social, economic, and regional disparities. Research consistently shows that prescribing patterns correlate with local resources, training, and community norms. What the page suggests instead, or what experts recommend. Although the article focuses on the data, it gestures towards widely accepted best practices. Non pharmacological approaches first. These include environmental adjustments, structured routines, sensory interventions, personalized activities, and caregiver coaching. They require time and training, but are far safer and often more effective. Medication only as a last resort. When, when antipsychotics are used, they should be time, time limited at the lowest effective dose, closely monitored, paired with a paired with a plan for tapering and discontinuation. Better staffing and training. System level improvements are essential so that caregivers have the tools to manage aggression without defaulting to medication. Why this matters for patients and policy. The article frames the rise in antipsychotic prescribing as a public health warning signal. These medications can shorten lives, accelerate decline, and undermine the dignity of older adults, yet they are being used more often, not less. The trend reflects a system struggling to meet the needs of people with dementia and the caregivers who support them. Improving this landscape will require investment in dementia capable staffing. Training in behavioral and environmental interventions, policy initiatives that reward non drug care, support families navigating frightening and exhausting behaviors. In short, the article argues that the current trajectory, neither inevitable nor acceptable, and that safer, more humane care is possible with the right structural supports. Okay, guys, that is your C. After dinner, I'll be back on with a D later on. So for now, Gator Wellness, take care, folks.